do a sweep, starting off the feet, the lower legs, and each time as I do a sweep, I'm looking at all the structures, both feet. I'm seeing the two dots of a tibia and a fibula on each side. I'm coming up to see that the femurs are present. I'm coming up to see whether the urinary bladder is visualized. I'm seeing if there's any dilated loops of bowel. I'm checking for the kidneys, I'm checking for the stomach, checking for the heart. As I go across, I see the hands on the right and the left side, the arm, the forearm, the hand. And then I come up to the fetal face, I see the increased fluid. And then I come up to the baby's jaw, face, eyes, orbits, and I see the cerebral fourth ventricle, which looks, I need to check this, but it looks dilated. So that's a single sweep that took me literally, 10 seconds. In a single sweep, I was able to go through this baby and see where we were. So now if I look at that fourth ventricle, I think that is the dilated fourth ventricle, but I want to get more images. As soon as I see the fourth ventricle is dilated and I see a cardiac abnormality with an increased nuclear translucency, I think of number one, digonic triploidy. 90% of babies with digonic triploidy will have a dilated fourth ventricle. Now it tends to be a much larger fourth ventricle. If you look at trisomy 13, about 70 to 80%, trisomy 13, trisomy 18, about 50%, and then Down syndrome. So the cerebral fourth ventricle is a very powerful marker. So this baby, do you see the difference in the imaging when I'm looking here compared to TA? It's completely different, right? So I know I did a lot of teaching in the last few minutes with you, but if I was here on my own, I would have spent very little time in that transabdominal scan, because when I looked at it, I said, the images are not good here. I would have taken a crown rump length, an abdominal circumference, a femur length. I would have spent 2 minutes, and then I would have gone to the vaginal scan. Yeah, because now I'm looking at a baby where the information that I'm getting is much clearer. If you're scanning a baby and it's in a coronal position in terms of doing a 3D volume acquisition, because sometimes it may not get into a nice position for doing a 3D volume acquisition later, then just pull back in your probe. Don't push your probe up too hard, because you always, when you're doing a 3D, you always want to make sure that you have fluid all the way around the baby. And sometimes we end up pressing too hard, pushing the baby up against the uterus, but if you pull back on the probe, even very gently, I've got the face up against it, so I'm not going to do a 3D. So anytime I want to get a complete volume data set, I make sure that I've got fluid all the way around the baby, and the most important maneuver is to pull back on the probe. So as I come across here, looking at the face, orbits, lips, I do a sweep. I ask myself, is the baby's heart in a good position? Now the problem I have with the baby's heart is when I come across here, I'm getting 4 ribs on this side and 4 ribs on this side. Do you see the point I was making earlier? That's going to be hard for me getting a good position of the baby's cardiac anatomy. It's not going to stop me, but I just know that the sections, I'm beginning to get better already, because I'm already just a slight rotation of the probe. I can see I've got 1 rib on this side. So I'm not too far off on it. So I say, okay, I am going to go for it. So then I change from routine, then I'm going to go to a cardiac preset. And straight away I've got a frame rate now up at 45 cents. If you look here, it was at 22, and then I go to a cardiac preset. It's gone from that, it's gone to 45. I've doubled my frame rate by going to a cardiac preset. Sometimes when I'm scanning in routine, I find I don't like the cardiac preset for 2D sometimes. I actually prefer the routine in 2D for the heart and the breast and meso. So then what I do is I reduce my sector width. And as I reduce my sector width, I'm now up to a higher frame rate. On the cardiac preset was 47. I'm actually up to, and if I take it one more down, I'm up to 53 hertz per second. So for me, that provides actually better detail. I then reduce my depth, okay? I never try and avoid total zoom. Total zoom is only just for fine tuning. I then, once I've got that on view, I'm not going to include my whole chest. I'm just going to take the heart. And then I do a very slight total zoom at this point. So as I look at this here, I can see the 4-chamber view of the heart. I'm looking to see, can I see a tricuspid valve and a mitral valve? I want to see the sizes of the ventricles, because at the beginning, when we very first started, we could only see 1 ventricle. But now I can see very clearly that there are 2. For this case, I will go to power Doppler. As soon as I go to power Doppler, I see all this color. And the reason I'm seeing all this color is because in this setting, because I'm on routine, in this setting it falls to a color of 8 centimeters. So now I get out of that. I get out of my routine because I've looked in 2D at the 4-chamber. I now go to a color preset. So look at the color preset, it's on 20. So now I'm on a color preset of 20, and I just select the heart with the descending aorta. And now magnify my image of the heart. And now I've got can see both cardiac, sweep. I can then see both cardiac chambers. I'll be quick. So I can see both cardiac, just move. So when a baby does that and turns and moves on you, that's okay. Just go and do something else. So you remember when I was looking transabdominally, I could only see one kidney. If the baby's in a good position, catch it. But then this is the point where I can actually see what the genitalia is. So capture, this is the very important use of cine loop. Okay, so it just flashed by me. I may not be able to see it again. So freeze it and cine loop, magnify the image, because for us, we have NIPT results before the patient has a 13-week scan. And therefore, if I see that the NIPT shows that this was XX and I see XY, then I know I have a problem. Okay, so that's looking at the point of the cord insertion to the abdominal wall, which looks normal. And now I'm just going to come up and take the open dissector width, because now it's moved into a good position. I'm going to very quickly go back to routine, going to magnify the image. Because when I was looking abdominally, I couldn't see the nasal bone, but I think I can actually see a nasal bone with the vaginal scan. When it's in that position like that, you need to look at the jaw to see whether there's actually any retraction of the mandible, and I look at the line of the mandible in with the maxilla. And as I come across, I can sweep the arm, the forearm, the hand, and the 5 fingers on that side, which looks good. And I can see it's a cystic hygroma, really, rather than an increased nuchal translucency. I can also appreciate as I come down onto a split image, it is much clearer transvaginally. As I split the image here, I can see that this here is the mandible, and this is the lower lip covering here, going all the way across, and this is the mandible. The mandible is a much acuter angle, whereas the maxilla is much wider. So if you actually calculate by doing it as they say calc, generic, and I don't do this, I'm just making the point. And you calculate the angle of here, going out from this bone here, out to this bone here, and you calculate this angle, it's 80 degrees, okay? Whereas the maxilla is much wider. So sometimes you're trying to say, which is the maxilla, which is the mandible? And by looking at actually how narrow the mandible is compared to how wide the maxilla is a very helpful clue. So as you come across there's your maxilla, and you can see the lip coming all the way across. You can see the nostrils. When it's in that position, by the way, just rotate your transducer, because you will get a nice facial profile in that position. When it's in a nice facial profile like that position, remember you have the option very quickly of catching 3D. I'll go to quality max, I'll select an angle around 60, acoustic out, too late. So you need to be very quick, but it'll come back. And then I get the patient to stop breathing. So when you get a measurement like this on a 3D volume data set, I don't want the render first. I just want the multiplanar. So I select my multiplanar. Once I have my multiplanar image, the next thing which I want to do is increase my volume speckle reduction imaging. And you see the way that gives a much contrast to your image. And then I magnify the image of volume contrast imaging, and then I translate through. And as I look through this, I can see that a nasal bone is present. To me, it looks like a small nasal bone. So if we look at this, and again, for most of these babies who have a small nasal bone at this stage, and that is a small nasal bone, I don't worry too much about it because I already have an NIPT result. The other thing which I want to show you is look at the maxilla. You divide it into thirds: the anterior 1/3, the middle 1/3, and the posterior 1/3. The vomer comes off the posterior 2/3, the junction between the 2/3, posterior 2/3, and anterior 2/3. So this structure here is the vomer. Why is the vomer important? Well, if you see a vomer, you know this baby does not have a hard palatal defect. If the vomer is absent, then you need to be suspicious that the baby's got a hard palate defect. So that's the vomer here, and the vomer sits on top, and I'll point it out to you to draw it for you. That's the vomer, and then sitting inferior to that, and that's the maxilla and hard palate. So by seeing the vomer there, that tells me it's very reassuring that the baby does not have a hard palate defect. So the baby moved last time, so it's now got back into a good position. I'm going to reduce my sector width, and now I'm going to go back to again. So you just need to wait and be patient and wait for it to turn, and when it turns, then you just need to go to a different position. So then I'm just going to go to the forward. I'm going to be quick now and stop talking so much, because I need to capture this. So I'm going to capture the forward chamber, and you see the way there's too much grey, so the balance here needs to be changed. So as you come down to looking at the forward chamber of the heart, I'm seeing too much grey, so I increase the balance. And when I increase the balance, you can see I get much purer flow with no grey images covering the colour flow images. It's off moving again. That's okay.
Yeah, one case of Casamate 18.
You have one.
Yeah.
And many weeks? That's fine, we can see her. Happy to see her.
Yeah.
Yeah.
Do you want to try?
Yeah, yeah, of course.
Cái này vòng 4 chuyện không, nhưng mà cái này cái thứ hai, vòng 4 cái này thứ ba.
Viện chính nó nói đưa qua thôi.
Thì cứ coi xếp hàng từ từ thôi. Người ta nói như vậy.
So when we look at this, remember I was talking about when you're doing a 3D volume acquisition, if you ever see the baby moving around like this, extremely active, you can also choose 4D. So when you choose 4D on this, so I'll ignite 4D, you now can see the fetus moving in real time. And for this you check HD flow. Now when you are looking at a baby moving real time in 4D, you need to check the frame rate when you look at this is very low. You've got a 4 hertz frame rate. But you can, if you reduce the actual your acquisition, you can actually make that a little bit faster. It's okay in this baby though. So when I look at the grey threshold, if I want to make it sharper, just try it yourself and see what the grey threshold does. Increases the grey threshold, or you're right in echoes by reducing the grey threshold. I think reducing the grey threshold of this baby is better. You see the difference that makes? You can see it's sucking its thumb, putting in and out of its mouth. And you can change this. You can change the axes. So as you come around and looking at this, you can also magnify. Be careful when you magnify, it doesn't come out of view. And you can also see details of the orbit and the fetus opening and closing its mouth. You can freeze the image, you can rewind the image, and you can see it opening its mouth just there. And when you see it's opening its mouth, that's another way of looking to see if there's any cleft lip, cleft palate. You can also, in that same move, if you look on a skeletal rendered image, you can see here the retronasal triangle, you can see the maxilla, you can see the frontal bones, and then you can go back and look in the, so you can jump from the, in real time, 4D, you can jump from these surface rendered modes to skeletal modes. There's also another rise, Long, you may be able to help me out here on this machine. It's, the skeletal tissue bone HD Live silhouette. Yeah, this is another nice rendered image, which is another. You can see the metopic suture. You can see the frontal bones, and then if you update that, you can go back. I need to unfreeze. And then this allows you, if you're suspicious of a skeletal abnormality in real time, you can see the bones of the arms, the bones of the legs. If you wonder where you are, you can split the image, and you see that the baby is outside your rendered image, your rendered box, and you can change your render box. Bring that back in. How do I bring it in on real rendered? How do I get my rendered box back in? I should be able to change my render box though, and it's not coming up here. I don't know why. Don't worry. Okay, there you go. So how did you bring that up? Okay. Oh, the pointer was on. Okay. All right. So if we look at this, we've now got this view of the baby lying in a sagittal section. If you're ever in that position, don't be afraid of inverting the image. And it's a good idea to get used to scanning in an inverted image. So now, this is the first time that allows me to take an accurate crown rump length, because before I hadn't been able to do it in the position the baby's in. You know what I think is the most difficult measurement in obstetric ultrasound? The crown rump length. And the reason it's difficult is because it's difficult bringing into view the rump end of the fetus. And then the next measurement we take is the nuchal translucency. It's not a perfect mid-sagittal. Oh, this is get rid of it. Yeah, man. So yeah, look, I don't have a facial profile. It's not a perfect measurement, but I still want to get this. I know it's not perfect, and I want to save that. Okay. So if the baby's in that position, just let me say to you, in the first trimester, if you have a baby, let me save a clip for you and just show you and say, that's a picture you're getting of the baby's heart. I'm just going to stop that recording. Hold on. Okay, so you're doing a scan today and you say, Simon, that's hopeless. I can't see anything because the baby's got this spine up and I can't see any detail of that baby's heart. How can you tell me there's a problem in the baby's heart? What I'll say to you is, and I'll save that as a clip, in first trimester, because the ribs are relatively translucent, is you can actually invert the image and you can get the details of the heart. And when you come to this and now magnify it, and you look at this seconds later, that's the same baby, okay? And if you record that now, by simply inverting the image, it's able to transmit ultrasound through the ribs, through the chest cave, chest wall, and you're able to get a 4-chamber view of heart. Now, you see the difference between those two images? They are completely different. So ask the patient to stop breathing for a second.
Mình đứng thở xíu nha.
Okay, breathe away normally.
Rồi, thở bình thường.
So these are the two images, okay? This is the first image I showed you. This is the first image I showed you here, where the spine was up, and I said to you, maybe I didn't. It's good. I said to you, you can't see anything in this baby, okay? I said you can't see anything because the spine is up. This is the second image in which you've inverted the spine and you see it. So I'm just making that point. You also appreciate when you look at this baby, it's got a pericardial effusion. So that's also another marker. When you see a pericardial effusion in any baby, most of them are benign, but if they extend up to the level of the AV valve, then they're going to be significant. So that is you look here, this is the right atrium just coming in here, this is the right ventricle, and this is the junction of the AV valve. When you look at that pericardial fluid, you see it extends beyond the level of the atrioventricular junction. And that for me is going to be a significant pericardial effusion. I don't have a figure for cutoff in the first trimester. I look to see, one, is it circumferential? Does it extend up to the right atrioventricular groove or not? That's the important thing. Okay, let's get on with going back to looking at the anatomy of this baby because I've been talking too much. So let's increase the acoustic output. Let's press P1, split the screen, and let me get a feel of the ventricles. See there's a VSD going across. There's your VSD going from left to right side, so it's a transposition with the VSD. Let's go back to this one. Stay very still. Okay, there's your VSD. There's your 4-chamber. And then let's go up to the 3 ventricle. There's your aorta coming out of your right ventricle. There. Now, because I've inverted the image, I have to invert my color. Just remember when you do that. So now my question is where's the pulmonary artery? So I have to find the pulmonary artery, and the pulmonary artery will be inferior. Okay, there's the aorta coming out of the right ventricle. So this here is your RV. This here is your LV. And this here is your aorta. And your aorta is coming out of the RV. So if I'm going to scan inferior to this, start my recording. Okay, so I'm not bringing it into view. So what I need to do at this point is I need to reduce my PRF to try and catch it. I've inverted the image again. It's an extremely active baby. So if the baby quietens down, I want to do a stick volume on this baby, but it's just so busy. there's too much color coming into that. Now, just watch very, very carefully, because once I come back here to below the level of this is the aorta up here, come back then below the level of the aorta, and I'm seeing a branch pulmonary artery just here. So the pulmonary artery is much smaller when compared to the aorta, and that's why I'm having difficulty seeing it in this baby. So it is a transposition of the greater arteries with pulmonary stenosis and a ventricular septal defect with an increase in translucency. Are we okay on time? Am I holding people up? Am I okay to keep going here, guys? It's okay to keep going because I just wanted to get an LVOT.
Pulmonary stenosis or atresia?
Yeah, but just give me a second now, because I want to see whether I want to see whether there's any flow into the right ventricle, because I'm seeing a central AV canal. See, there's a big central VSD. Do you want me to finish up here?
Chịu khó xíu nha chị.
No, I just
Khó
need
chịu
to.
quá nói bác sĩ nha.
Okay, so next, I just want to catch a 4D. So for 4D, it takes stick, 15 seconds, and there's a small, it's first trimester, so 25 should be fine to get an angle. Once I've got everything is set up, I then catch the 4 chamber. Excuse me. The baby's too busy to do a stick, but I just want to show you how to process it. It's just moved. No, not possible. All right, does anybody want me to show anything else in this baby? Let's try again. So what I'm beginning to wonder is whether there's a central AV canal defect, not just a VSD. So this here is the VSD from here to here, right? We saw that on color Doppler. What I'm trying to work out is there a central AV canal defect? So if you look at here, it looks like a common valve. So this to me looks like an AVSD just here coming across. When you see that, remember to press this cine loop on it. So I'll press P1. Yeah, there's a central AV canal defect. Okay, and then when I come across on this, so it's quite a complicated case. When I come across on this, I'm going to now go to slow flow. So let's go to slow flow and see if I can get more definition. On my slow flow, I'm going to select back to a map of 4 and come back, and then there's too much balance, so I'm going to write in more color, and I'm going to pull back on my acoustic output, I'm going to pull back on my gain, and then I'm going to go back into gradient max, and then I'm going to try and find my pulmonary artery. So I'm going to do a split screen. You can see the subclavians coming off normally. Nice normal subclavians. Aorta, SVC, 4 chamber, split screen. So in the central AV canal. And maybe stop moving. The aorta just coming out from there. Reverse boomerang. And then inferior to this, these are the branch pulmonary arteries, which are very small. So this is the branch pulmonary arteries coming out here and here. So that's why I'm struggling to see them, because they are extremely small branch pulmonary arteries coming out. Anytime you see the branch pulmonary arteries coming out, you always ask yourself the question, could it be a truncus arteriosus coming out of the right ventricle? And I don't think it's a truncus arteriosus because of the configuration that I'm seeing of the reverse curvature. So if I look at a single final sweep, I'd see start off the stomach, looks good. The 4 chamber, I can see there's a central AV canal defect. I can see the pulmonary veins entering normal into the left atrium. As I sweep up to the head and the neck, I can see that there's reverse curvature of the aorta coming out of the right ventricle, which is there. And then inferior to that, I'm seeing very, very tiny branch pulmonary arteries. So it is, in summary, a complete AV canal defect, transposed great arteries, pulmonary stenosis. Yeah, with an increased nuclear translucency, and I haven't seen anything else. You cannot do for stick, unfortunately, with slow flow. You can, however, do a 3D volume acquisition. Why is it set up for first trimester? Angle 50, acoustic output 100%. Baby's moved again.
How do you think about the prognosis of this case?
The prognosis. Anytime I'm faced with a baby who's got a cardiac abnormality, I get a pediatric cardiologist involved.
Pediatric.
Oh,
And the pediatric cardiologist cancels the patients on the outcome. I'm an obstetrician.
yeah.
So in a scenario when I make a first diagnosis, I offer chorion biopsy, and by the time next week I bring the patient in, we do a cardiac list every Tuesday afternoon. Next day is on the Tuesday afternoon, we have the result of the FISH. We don't have this CMA, and then we see the patient with the pediatric cardiologist, and then we counsel about the outcomes. But as an obstetrician, I would say a complete AV canal defect, transposed great arteries, and it's quite severe and very hard to see the pulmonary artery. I would say that it's a poor prognostic cardiac abnormality. But I say that as an obstetrician, not as a pediatric cardiologist. Yeah. The second point to make is any time I see a baby with a complex cardiac abnormality in the first trimester with increased nuclear translucency, it's more likely to have a genetic basis
Yes.
than just a simple TGA. Because the very start, we thought on transabdominal scan, increased nuclear TGA. Most babies with TGA do not have an increased nuclear translucency.
Yeah.
Yeah, so it's more complex.
Yeah.
Yeah. We were unlucky today because the baby was so active. It's non-stop movement since the beginning of the scan. Actually, it's just quieting down there now, but it has just made it a little bit more challenging. The other thing I believe is I think slow flow makes babies move. I think that's probably a contributing factor. So let's take off slow flow and we'll look at one more time with God. There's your VSD coming across. Just reduce your PRF, stay the same, increase acoustic output, increase color gain. Then do 40 stick, 15 seconds, 25 degrees. Stop breathing.
Ngưng thở chút cho em, nín thở chút.
Breathe away normally.
Rồi,
Thở
thở
lại,
bình
thở
thường.
That's all the crazy sort of wide course of the aorta coming out of the right cardiac ventricle.
How could you differentiate between the right double outlet with the TCA in this case?
So I don't understand, so there's your VSD. So I say again, how is
How,
it?
how do we differentiate between a double
Outlet right ventricle with TGA.
Yes.
Very, very good question. I can't on the imaging I've seen. Yeah. The double outlet right ventricle with transposed great arteries has a subpulmonary VSD. And seeing that there, I can't tell you which of the two it is. So I don't know. Yeah, it's a very good question. I don't know. Because that's your major differential, double outlet right ventricle, transposed great artery, subpulmonary VSD, with a versus having a transposition of the great arteries with an AV canal. Yeah, it's a very good question.
So she's feeling uncomfortable.
Uncomfortable. Okay, we'll finish up. I just want to try and get one more volume. Okay, nearly finished.
Thế có một đại động mạch không?
Hai nhỏ thì biệt thôi.
Rất là nhỏ.
Nó không khai nên từ từ nó sẽ vô gặp mọi người lâu dài.
Cái gì?
Stop breathing.
Nín thở xíu nè.
Trời ơi, tại vì đọc hay quá mà.
Breathe my nose.
Rồi thở bình thường. Sắp xong rồi nén xíu.